Hi everyone, and welcome to our module on neurotransmitters. In this module we're going to talk about neurotransmitters in the central nervous system, but don't get confused by the fact that these neurotransmitters also have effects in the peripheral nervous system. So norepinephrine, acetylcholine, and dopamine are all used by the sympathetic and parasympathetic nervous system to exert peripheral effects. But in this module we're going to talk about what happens when these neurotransmitters do their jobs in the brain. So these are the key neurotransmitters that you should know about in the central nervous system: norepinephrine, acetylcholine, and dopamine, and these all also have peripheral effects. And then serotonin, GABA, and glutamate. And we'll talk about all 6 of these in this module today. So first we'll talk about norepinephrine, and this is a stress panic hormone, and that should be easy to remember because it's used by the sympathetic nervous system peripherally as part of the fight or flight response. Levels are increased in patients with anxiety disorder, and they're decreased in patients with depression. And many depression drugs work by increasing norepinephrine levels in the brain. So for example, the SNRIs, which are serotonin norepinephrine reuptake inhibitors, these drugs increase norepinephrine levels in the brain for depressed patients. Also tricyclic antidepressants like dicipramine and monoamine oxidase inhibitors, which are very old antidepressants, these all increase the levels of norepinephrine in the brain of patients with depression. Norepinephrine is synthesized in the brain in a place called the locus ceruleus, and it's in the pons in the back, right near the fourth ventricle. It's the main source of norepinephrine for the brain, and this area is critical in the response to stress, which is easy to remember because you need norepinephrine for the response to stress. There are extensive projections from here that go to other parts of the brain to send norepinephrine where it needs to go. And when people have done studies on lab animals and some on patients, they find that the locus ceruleus is very active in opiate withdrawal. And that's also relatively easy to remember because patients withdrawing from opiates have their sympathetic nervous system ramped up. They're very agitated and tachycardic, so it makes sense that this area of the brain would be active in that situation. Next we'll talk about dopamine in the central nervous system. It's synthesized in the ventral tegmentum and the substantia nigra. These are both found in the midbrain. And you may know the substantia nigra is part of the basal ganglia. Levels are increased in schizophrenia, and this is why dopamine blockers like haloperidol are effective treatments for schizophrenia. Dopamine levels get low in Parkinson's, and that's why drugs that agonize the dopamine receptor like levodopa-carbidopa are used for treatments in Parkinson's. And then finally, levels are also decreased in depression. Here's a picture of the brain, and this is the ventral tegmentum area here, and this is the substantia nigra area right here, and they project to other areas of the brain to exert the dopaminergic effects. GABA is gamma-aminobutyric acid, and it's a very abundant neurotransmitter in the brain, and it's largely inhibitory, and you should remember this because it will help you remember the effects of many of the drugs that work on the GABA system. When you activate the GABA system, you tend to quiet down central nervous system activity. This means you get less things like seizures and you get more sedation, which is how many anesthetics work. GABA is synthesized in the nucleus accumbens, which is in the subcortex. And there are low levels in patients who have anxiety disorders, and there are also low levels in Huntington's disease. So here's that picture of the brain again, and the nucleus accumbens is here, sort of in the front part of the brain in the subcortex. So there are several anesthetics that work through GABA. Since GABA is inhibitory, if you inhibit the central nervous system, you get sedation and people get put to sleep. So etomidate, propofol, benzodiazepines, and barbiturates, these drugs all activate the GABA receptor, and that leads to their sedation effects. So you should know something about the GABA receptor. GABA binds to its receptor and allows chloride to enter neurons, and chloride is negatively charged. So when it enters the cell, it hyperpolarizes the membrane, meaning it makes it more negatively charged. This makes it harder for the neuron to depolarize and conduct an action potential, and that's how GABA exerts its inhibitory effects in the central nervous system. GABA is synthesized by an enzyme called glutamate decarboxylase in neurons. It converts glutamate into GABA. It's also broken down by an enzyme called GABA transaminase, and both of these enzymes need vitamin B6 as a cofactor. There are many symptoms of vitamin B6 deficiency, but one of them is seizures, and the reason for that is that you lose these enzymes which produce GABA in the central nervous system. There are 3 GABA receptor subtypes: GABA A and GABA B and GABA C. GABA A is the most important one. It's found in the brain along with GABA B, and then GABA C is found in the retina. Benzodiazepines act on GABA A, and they stimulate more chloride influx into neurons. Alcohol, zolpidem, and barbiturates also work on GABA A. Zolpidem you may know as Ambien. It's a sleeping pill, and barbiturates are anti-seizure meds and also sedatives, and they all work on GABA just like benzodiazepines. Let's talk about the nucleus accumbens. Remember I told you that's where GABA is synthesized, and from a lot of animal studies we've learned when the nucleus accumbens gets activated, and we've learned that it's important for pleasure and reward. There are also a lot of animal studies, mostly in rats, showing that the nucleus accumbens gets activated when people are addicted to drugs and in settings of fear. Next neurotransmitter is serotonin. It has various functions in the brain. We don't understand all of them. It's synthesized in a place called the raphe nucleus, which can be found in the pons in addition to other locations. I'll show you a picture of that in a minute. There are low levels of serotonin in patients who have anxiety disorders, and there are also low levels in patients with depression. And many antidepressants work by raising the levels of serotonin. Serotonin is also called 5-HT, which stands for 5-hydroxytryptamine. So the SSRIs block the reuptake of serotonin by neurons and therefore increase the levels in the synapses. The SNRIs are serotonin norepinephrine reuptake inhibitors, and they increase serotonin levels. And then the monoamine oxidase inhibitors, which are very old depression drugs, block the breakdown of serotonin so that levels rise in the brain. Here's a picture showing the raphe nuclei. There are several of them in the brainstem, most in the pons, and we think this is where the SSRIs exert their antidepressant effect, and this is where serotonin gets synthesized. You should be familiar with the serotonin syndrome. This is what happens when there's too much serotonin in the body, and this can occur with any drug that increases serotonin levels. So the SSRIs can do this, the MAO inhibitors can do this, SNRIs, which are serotonin norepinephrine reuptake inhibitors, can cause this, and so can tricyclic antidepressants. And all these are depression drugs, so patients with depression may have a suicide attempt and overdose, and they can get the serotonin syndrome. It can also happen if you take one of these drugs along with something that interacts with it. There's a classic triad of symptoms that you should know. The first is mental status changes, so these are things like anxiety, delirium, restlessness, and disorientation. Patients also get evidence of autonomic hyperactivity, so they will be sweaty and their heart rate will be fast, and very importantly, they will have a fever. That's hyperthermia. And then finally, they have neuromuscular abnormalities, so they can have tremors, they can have clonus, which is rhythmic contractions of muscles in their arms or legs. They can have hyperreflexia, and you can even see bilateral Babinski signs. So you should think of this in a board question. When you see a patient on antidepressants who comes in with fever, confusion, and rigid muscles, they may be describing the serotonin syndrome. Now, it can be confused with another syndrome called the neuroleptic malignant syndrome, and this happens to patients who take dopamine blockers like haloperidol, and some psychiatric patients are on both serotonin drugs and dopamine drugs, so there's a lot of literature out there on how to tell the two syndromes apart. Both syndromes have rigid muscles and fever and changes in mental status and autonomic instability, but the thing that helps distinguish them is in neuroleptic malignant syndrome, patients have lead pipe rigidity. Their muscles are fixed and contracted, and they have evidence of muscle destruction when you test their blood, so they have high CK levels, and you don't see these things in the serotonin syndrome. In contrast, patients with serotonin syndrome have clonus, so they'll have rhythmic contractions of their muscles, but not this lead pipe rigidity, and that's part of how you tell them apart. The treatment for serotonin syndrome is cyproheptadine, which is a serotonin antagonist. It is also an antihistamine, but it has significant effects blocking serotonin receptors. Next neurotransmitter is acetylcholine. It's synthesized in a place in the subcortex called the basal nucleus of Meinert. When you are sleeping and you enter REM sleep, your levels of acetylcholine in the central nervous system increase. There are also decreased levels in Alzheimer's because of destruction of acetylcholine-producing neurons, and some of the Alzheimer's drugs work by increasing acetylcholine activity levels in the brain, and then levels of acetylcholine are also decreased in Huntington's disease. Glutamate is the major excitatory neurotransmitter in the central nervous system. I sort of think of it as the opposite of GABA. It works on a receptor called the NMDA receptor, and that stands for N-methyl-D-aspartate. And one important clinical correlate of glutamate is Huntington's disease. We think that the way neurons die in Huntington's disease is from a process called glutamate toxicity. So in this process, glutamate binds the NMDA receptor, and that normally triggers an influx of calcium, but in patients with Huntington's disease, the influx is excessive, and this leads to death of the neurons in that disease. Finally, I'll mention PCP, which is phencyclidine. It's also called angel dust. It's a street drug that people smoke or inject, and it's an antagonist to the NMDA receptor. It has a similar mechanism to the anesthetic ketamine. And at low dosages, it sort of numbs people out, and that's why they like to abuse it. But it can also go on to cause violent behavior and hallucinations. And patients who present with PCP intoxication to emergency rooms can be very aggressive. They're usually stumbling because they have ataxia, so they can have falls and loss of balance. And at physical exam, they have nystagmus, so their eyes will oscillate either up and down or side to side. They can have vertical or horizontal nystagmus. They also have hypertension and tachycardia, and they're very sweaty, and high dosages of PCP can even cause people to go into a coma or die. And that concludes our module on neurotransmitters.